obstetrician, gynecologist, and reproductive endocrinology and infertility specialist. Welcome to Fertility, Fact or Fiction. Tonight, we're going to be discussing whether or not the Receptiva DX or BCL6 test works to detect endometriosis and helps to improve your chances of success with infertility treatments, and whether it can help guide decisions and so on. And if you like this video, make sure you go down to that like and subscribe button and click those and join us for all our other videos. And make sure that you give us some comments to help make the show better all the time. So we decided to pick this topic because we've had a lot of people, pretty much every show, saying, what about the Receptiva DX test? And, you know, how does this help us? And can we do it? And should we do it? And so on. So let's talk a little bit about the whole gist of this and why testing is done. Anytime someone either has a limited number of embryos or has failed embryo transfers, people want to know if tests will improve their chances of success. What kind of tests can we do? What sort of things are available? What sort of adjunct treatments can we do? And there is a world of possibilities here. For iGenomics, you have the ERA test, which we have multiple videos on, all of which have been shown not to be useful. From iGenomics, you have the Emma and Alice test, which have no clinical validity because there's no science behind it, but may actually be useful. From Fertility, the company that we use, you have immunological testing, which has entire journals dedicated to it, but still no agreement on whether or not treatments are beneficial or detrimental or not helpful at all. And then you have the infection testing from the endometrium. Many people will propose doing surgery to evaluate for endometriosis or for endometritis. And then on top of that, you have Receptiva DX. So Receptiva DX was the brainchild of one physician in particular, and a group of obvious colleagues and business investors who thought, let's find out what specific proteins are expressed more commonly in the endometrium of women who have a history of endometriosis. And then let's take that sample, use it to determine if patients have endometriosis, and then custom tailor their treatments towards the patients that have endo so that you can use either surgery or medical treatments to improve those outcomes. And so the idea is, let's find a protein or proteins, see if they actually alter your chances, and then based on that, decide what would we make our next step. Should we operate on those people? Should we give them medical treatments, but treat them differently from the people that don't have that protein, because in that specific group, you're assuming that they have endometriosis based on that one test. So the first question is, how valid is this? So the study originally was called endometrial BCL6 overexpression, and that's B-cell lymphoma 6 overexpression in Ectopic endometrium of women with endometriosis. So that's endometrium inside the uterus of the woman. But they were also at laparoscopy found to have endometriosis. So the main author for this is Dr. Bruce Lessig, who's a great guy, and I have the utmost respect for him. So he analyzed in a case control fashion women that were undergoing laparoscopy for having their tubes tied, women that were undergoing laparoscopy for endometriosis, and then also women with unexplained infertility. And they basically analyzed women who were willing to undergo an endometrial biopsy and then tested those biopsies for the expression of BCL6 compared to the control group, which were the women who were having their tubes tied. So we can pop this one up, or we should still be connected, right? So if you see this graph, and I'll try and blow this up for you, it's going to look like total gibberish, but I want everybody to kind of highlight on this. So when you look at this graph here, what you really need to focus on is that if you look right in the red, over here is probably the most important graph. So the short bar shows that there are very low levels of expression of BCL6 in women that are fertile. The ones that were going through laparoscopy as controls also had very low levels. But the ones that were going through laparoscopy for endometriosis had extraordinarily high levels, which are right there on top of that arrow that I've drawn for you, as did the ones that had unexplained infertility. So this is great data because it's showing your fertile control group, or even just the laparoscopy control group, have way lower levels of BCL6 than the group that has unexplained infertility and or endometriosis. But the problem is we don't know how many of those unexplained infertility patients actually have endometriosis. More importantly, and more to the point, we also don't know, and there isn't really great data on how many of these women had other conditions that could potentially lead to BCL6 increases, such as infections in the uterus or endometritis, because endometritis, which you can't just measure pathologically, you actually have to look at molecular level RNA or DNA from bacteria and viruses to really detect their concentrations there, was not analyzed in this study. And therefore, it's really hard to know if these women have something that could have artificially increased their levels of BCL6 compared to the other women. There's certainly some promise here, I'm not questioning that, but there are some features of the study that can easily be criticized. So bottom line was, from this study, they said, hey, look, we've got these super high levels of BCL6. Because we've got these high levels of BCL6, maybe we should be looking at whether or not this is predictive. So the next study that was much more recent was looked at, and this is from Nezat group, which does a ton of laparoscopy. And their data is kind of hard to analyze and read, but I'll show you what they, or at least tell you what they had. So they had 75 patients included in the study, and they had demographics, and they basically said the age and the body mass index was all pretty reasonable, although most of the women were very thin. Their mean body mass index was only 23, which is unusually thin for the US in particular, and in general for all patients. So they did say that the positive predictive value for histologically proven, so this is a biopsy done study, plus visually diagnosed, so then they mixed in visual diagnosis, for type 1 and type 2C endometriomas was 96% when they looked at BCL thresholds as a detection marker for knowing if the patients had endometriosis or not. 3/4 of the patients had a histologically confirmed diagnosis, while 21.3% were diagnosed visually. So, 3/4 of them actually had pathology where they had a biopsy and it proved it. 1/4 of them, or 1/5 of them, actually didn't have a biopsy. They just saw it by looking at it. Now, that's arguable because what you think might be endometriosis isn't always. And I've operated on patients where I literally said to them, yeah, it was definitely endometriosis. And we later found out it was not, because the pathology will come back as a chronic corpus luteum or a chronic hemorrhagic cyst or something like that. So it's not as valid, but it's reasonable. Now, they did mention in this study that a substantial number of patients did have endometritis on their biopsy, and that does artificially inflate the levels of BCL6. So they didn't test everybody, but it's important to note again that what kind of testing you use to determine endometritis is also really important. So based on Bruce Lessie's first study and then this Nezat study, it would appear that there is some validity to the idea that you can use the BCL6 to predict endometriosis. However, what's also important is the other studies. So in this study, and I could only get the abstract, unfortunately, but you can see here that it says decreased BCL6 and increased the BLIMP1. I don't know why someone would name a protein BLIMP1 in the peritoneal cavity of patients with endometriosis. So when they washed out the pelvis of these women and looked at the peritoneal fluid that was there, the peritoneal fluid actually had lower levels of BCL6 in the women with endometriotic lesions. So this immediately makes you say, well, wait a minute, why is it increased in the uterus, but it's decreased in the pelvic cavity? And the answer is, I don't think anybody knows, but it certainly kind of questions whether there is validity to the levels. There was another study, which unfortunately I could not find the reference for, but I did see the other day, and I forgot to save it at the time, that showed that there was no difference in BCL6 levels between patients with endometriosis and patients that did not have endometriosis. Most recently, there is another study, and I'll show you the cover for this one. So we'll just flip back here. So this one is called B-cell lymphoma 6 expression is not associated with live birth in normal responder in vitro fertilization population. This is brand new. It's a 2021 article, and so it's quite recent. And so this article essentially shows you that when they analyzed the outcomes, there was no significant difference in live births for normal responding people who had their BCL levels tested, whether they were, positive or negative, and they had a threshold cutoff. There was no difference in success rates in this group. So if you're taking general IVF patients who are not ones that have had recurrent failures or evidence of endometriosis, this does not appear to be a valuable test in that general population. Could it be helpful for women with recurrent failures? Well, we don't know. There actually aren't any direct studies showing that if you take women with recurrent failures, do the Receptiva DX test, and then try and treat them with something, and then look at the outcome, that it actually makes a difference. We just don't have that study yet. So at the moment, is Receptiva DX a useful test? Well, it may, and I emphasize may, help you detect endometriosis. It's possible. We still don't know for sure, but it certainly looks probable that BCL6 is in some way associated with endometriosis based on several studies that exist. But is it helpful in determining your chances of, achieving a live birth? No. And do we know that it can direct your treatment? Well, there is one study that has shown that if you get treatment after you have noted that your BCL6 level is increased, it does improve the chances, but that is the one and only study that is available. And I don't think we're quite ready at the prime time level yet to say that this is valuable, because we don't have a prospectively done study where everyone was assessed moving forwards, the endometriosis was validated, or even just the BCL6 was validated, and then they moved forwards with the various treatments standardized between study populations. So at the present time, when people ask us, I tell them, do not bother with this test, because it's not going to help us very much. And the reality is there is no substitute test for endometriosis that has categorically been proven to demonstrate that you do or do not have endometriosis. We're not talking about endometriomas, the cysts that the Nazat group looked at. We're talking about endometriosis, where you might have tiny flecks of it. So I don't support the Receptiva DX test. That's not to say that it doesn't work, but it is to say that I don't think we have enough data yet to support its use. On their website, they have a number of new studies that are coming, but they're all in poster format or from conferences, abstracts, and so on. There's not a lot of published data yet, a total of only about 6 or 7 studies on BCL6 and its relationship to both infertility and endometriosis. Hope you enjoyed that part of the show. We always want you to click that subscribe button and make sure that you tell us whatever comments you have so that we can share it with others. And we will take your questions live.
What would happen to a developing embryo if I contract the Omnicolon variant, even if I got the booster? Because I know that the variant is highly transmissible and that there's strong chance we will all come in contact with it, and I fear success of my next transfer in January.
So if you are vaccinated, you have a lower chance of getting it, but you still can get it. And I've spoken to several people. In fact, one of my patients today, fully vaccinated, who couldn't come into her obstetrical appointment because of the fact that she got COVID and did test positive. So you can get it. So patients who get COVID, in pregnancy have a much higher risk of pregnancy-related complications: miscarriage, stillbirth, preterm labor, premature rupture of membranes, ICU admission, God forbid, even death. However, vaccinated women have a much, much, much lower incidence of those complications. And therefore, your chances, if you're vaccinated, are much lower, because vaccinated patients, even with Omicron, do not tend to get hospitalized or get severe illness. So do we have enough data on boosted patients, non-boosted, vaccinated, non-vaccinated within the pregnancy realm to tell you that it drastically decreases your risks of Omicron? Of course not, because this is brand new. But the reality is that if you're vaccinated, we know it is very protective at preventing severe illness and hospitalization for Omicron patients. Rates of hospitalization in South Africa, where Omicron came from, have drastically gone down. And so as a result of all of this information, it does not appear to significantly increase your risks of complications. And we would anticipate, and I want to make sure everybody understands, I'm saying anticipate, that it would not have significant pregnancy-associated complications either. But you still need to be careful, wash your hands constantly, wear your masks, avoid other people. I saw an absolutely hilarious little video today called God's Tech Support. And it has a guy sitting behind a computer who's obviously in heaven, and someone is calling saying, they're complaining about the pandemic. And he says, oh, well, you have lots of good tools down there to deal with the pandemic. We sent you the tests and we sent you the vaccines. And they say, well, we don't really like those. And the guy's just saying, basically, well, we can't help you even in heaven. So the bottom line is that, there are all these things available to us as tools to fight this, whether it's masking, washing your hands, getting vaccinated, getting tested. I don't care which one you want to choose, but there are things you can do to prevent getting this illness. And you should be doing those, and especially being vaccinated, in order to promote safety and hopefully getting over this for all of us.
What could cause a high level of prolactin?
Well, the number one cause of high levels of prolactin is when the part of your pituitary that produces prolactin gets a small sort of swelling or enlargement, and that's called a pituitary microadenoma or a macroadenoma, and that will expand the amount of cells in that area, and they start to produce a lot more prolactin. Other things that can do it would be medications, especially psychotropic medications, medications for people that have hallucinations or schizophrenia can increase your prolactin levels. There is certain medications for your bowel and gut that can affect your levels, which we actually use to help patients make more breast milk. And then there are other things too. Breast implants can do it. Chest trauma can do it. So all of those things can contribute.
36. Unexplained secondary infertility. Starting IVF, should we PGT test or not? Waste the money.
That's a good question. So studies would support not doing it unless you've had recurrent losses. If it's just unexplained, I would not necessarily advocate for doing it. We would tell you to do it if you're over 38, but at 36, it's probably not necessary. However, I do believe each case should be individualized. So look at how many embryos you get. I mean, obviously, if you have a ton of embryos, then you probably don't need to do it because you're going to have a lot of embryos. And so, there's enough to run through. If you only have a few and you want to know why you went from, let's say, many eggs down to just a few embryos, then yes, of course, because if you're ending up with all genetically not normal embryos, that's a problem.
Mark, RE found placental tissue inside the gestational sac at 6 weeks and 4 days. It looks like a pretty large mass on ultrasound. Is this very harmful? 5-day FET, 119 heartbeat, HCG 86,000, 40 progesterone.
How far along was it?
6 weeks, 4 days.
Well, I've never seen placental tissue, so I would be questioning if your RE saw what they actually think they saw. It could be a bleed, it could be a polyp, it could be a fibroid. There could be a lot of other things. If you have placental tissue growing at just 6 weeks, then there's definitely something unusual. And I'd be wanting to know if there was the chance of a molar pregnancy, and a beta of 86,000 at just 6 weeks is quite elevated. So that would be unusual, but I would be wanting to see those images myself.
Is Lexapro safe?
Lexapro. God, why am I blanking on what Lexapro is? Let's look up Lexapro and then I'll tell you in 2 seconds. Well, I guess I can use this guy, right? Ask me the next question and I'll look up Lexapro.
Yeah, sure. Can you explain what the normal range for a male's SA, specifically total count and motility?
Oh, escitalopram. Sorry. Lexapro is escitalopram. No SSRI, of which escitalopram is a group, is a member of the group, selective serotonin reuptake inhibitors, is considered safe in pregnancy. They all have potential effects on the fetus, including usually heart and lung development issues. But there is not enough data to support saying yes or no on this specific one. However, in general, we always balance the risk of complications with your fetus against risks of complications with your mental health. So if you don't need an SSRI, don't be on it. Of course not. But if you need it for your mental health, then of course you need to be on it. So we always have to balance your well-being versus the baby's well-being. And your well-being is paramount, because if you're unstable, then there's very little hope for the baby, with a stable, safe, healthy, happy outcome for the whole family. So you need to talk to your physician or your psychiatrist or your obstetrician about these kinds of issues to make sure that you are fine, the way you are, or that there are alternatives for you that are safer. Okay, what was the male factor question?
Yeah. Can you explain what the normal rate for a male's SA, specifically total count and motility?
Motility, according to the World Health Organization, should be over 40%, with at least 32% being what they call progressively motile, meaning it's moving forwards. Count should be at least 15 million per milliliter.
Would you recommend the booster 2 weeks post IUI?
Whoa. Technically, I'm supposed to, but I'm going to say no. 2 weeks post IUI, I'd probably hold off. I'd probably just wait a few weeks until you make sure you see an embryo and a heartbeat, and then you're probably fine to go ahead.
Dr. Victory, thanks for all your videos. Is there anything you recommend to increase uterine lining thickness? Last cycle, 5.7.
Yeah, there's loads of things you can use. So various forms of estrogen, Viagra, vitamin C, E, D have all been shown to do it. Aspirin is probably helpful. Acupuncture may or may not work. We reviewed Viagra, and then we just reviewed the effects of PRP, and we just had a conference call with the provider of PRP, Arthrex. And they're going to be sending us their system in the new year. So we will start doing PRP treatments for our patients with thin endometrium or failure to respond or failed implantation cases where it's also been shown to be quite beneficial. So there are a whole host of things you can do. And in some cases, you need to do either evaluation for infection with the Fertility testing that we do, or you need a hysteroscopy to make sure there's no scarring or adhesions in there holding the lining together.
Do you believe sperm lives in the female body for 5 days? If so, why do IUIs have such a low success rate?
So sperm likely lives in the female body for up to 3 days. There are studies that have shown that. So it's certainly possible that there is live sperm there. Now, we don't know if that applies to all sperm, but we know it applies to some sperm in studies that were done. With regards to why does IUI have a low chance, I mean, natural conception does not have a super high chance. So IUI is really just a modified version of a natural conception. So we anticipate that you're going to have relatively similar success rates. between IUI and natural conception for people that don't have fertility problems. It'll obviously be a little bit lower in IUI because you have a fertility problem, and that's why you're doing the IUI to begin with. So the duration that the sperm is alive is only one factor. The speed of the sperm, the number of the sperm, the quality of the sperm, your sperm DNA fragmentation, egg quality, body mass index, social habits, smoking, drinking, drug use. All of these things can contribute to success. The number of eggs, the quality of the uterus, is there endometriosis, are there infections, what's your background health history, what medications are you on? There are numerous factors that go into this. So you can't just say, why are IUI success rates low? We don't know.
What are your thoughts on human growth hormone for low AMH patients?
So there is data demonstrating that you will get a higher number of mature eggs if you use human growth hormone. So we do use it for some of our patients. However, it only increases the number of mature eggs. So if you don't have a problem with the number of mature eggs that you're producing based on previous successes, I wouldn't advise using it.
Is it helpful if you can't get a laparoscopy? I've been on a waiting list for 14 months now with an excision specialist.
Is the Receptiva DX helpful? Not really, because it's just going to tell you have endo and you still need to treat it, which means surgical or medical treatment. So if you're asking about the Receptiva DX, no. I don't know why on earth you'd be on a wait list for 14 months, though. I mean, unless you have very, very severe endo and you're waiting to see one of our gurus in Canada, like my previous junior resident, Sony Singh, I don't know why you'd be waiting that long. Like, that seems abnormally long. Maybe just set up a consult with us and we can see if we can find you help much faster than that, because it shouldn't take that long.
My doctor has chosen not to do a cyst excision and go ahead with the IVF cycle and saying they fear losing the reserve of ova. Would you suggest a cyst excision? Is it a must? 36 low AMH.
Yeah, so the problem with endometriomas or cysts in general in your ovary is that the presence of the cyst reduces your AMH level, and removing them also reduces your AMH level. So the longer you leave it there, the more your AMH drops. And when you take it out, you also see a drop in your AMH. So it is very much a case of damned if you do, damned if you don't. So again, I think medicine always needs to be individualized. If you have a small cyst, it's accessible, it's not huge, and it's simple to take out. Yeah, of course, get it taken out. There's no question, because it's likely going to have very minimal compromise on your ovary, especially if you're with a good surgeon that knows how to not damage the ovary in the process. If you have a larger cyst, it's compressing the whole ovary. It could do a lot of damage to the ovary. That's another story. Then you got to decide, is it worth trying to do the IVF first, then go after the cyst, because you may be able to get eggs from around it? Or conversely, is the cyst so large that it's obstructing any production of eggs because it's taken over the whole ovary? And that can happen sometimes, in which case you're kind of coerced or forced into actually going and taking out the cyst. So I'd have to know more details about your specific cyst, but it's a very simple discussion to have with your fertility specialist. I will say this, and I think this is really important. The vast majority of fertility specialists no longer do surgery. I think I'm literally one of the few that still does large-scale surgeries, including hysterectomies, myomectomies, and so on, and all of the laparoscopic stuff. So a lot of them do not want to lose you as an IVF patient. They just want to ram you through IVF because you're a dollar sign. And if that's the case, you're with the wrong doctor. I'm not suggesting you leave who you're with, but you need to have a long, rational discussion, and they need to be able to quote you the numbers, the durations, the timelines, the costs, the impacts, all of that stuff, and justify what they're suggesting to you. If it's just, hey, I've got a cyst, you should go for surgery or for IVF, that's one, size fits all, and that's cookie cutter medicine, and you deserve better than that.
My doctor has chosen. Have you ever seen an ectopic pregnancy in an IVF patient with categorized tubes?
I've never seen an ectopic in an IVF patient with cauterized tubes, although tubal cautery only accounts for usually 2 to 3 centimeters of the tube is what you're supposed to cauterize. And you're cauterizing it about 2 centimeters away from the cornua, which is the sort of side of the uterus where the tube comes out of. So the dilemma is you still have a little bit of tube. If during your embryo transfer, they either went too high or the embryo itself just happened to decide to take a joyride through the uterus and go up the tube for whatever reason, you can definitely still get an ectopic pregnancy, because if it implants there, it's right up near the corner of the tube, and that can be a problem.
Before the first pregnancy, the doctor prescribed clomiphene to regulate the period, and next month ended up with triplets.
Whoa.
What are the chances of twins or triplets again if not taking the same?
If not taking the same. Okay, so your chances of twins with Clomid and letrozole is between 5 to 8%. Your chances of triplets is less than 1%. So you had a lot of babies from your dose of Clomid. Maybe they gave you too high a dose. Your chance of having twins or triplets again without the medication would be low. Your chance of having twins or triplets again with the medication would be the same, maybe even higher. So 5 to 8% or more based on the fact that you previously had twins. And you can calculate it if you know how many eggs you have. If you're producing more than 2 eggs, your chance of twins goes up dramatically.
Follow up to that is also trying to conceive naturally and do not want multiple since my first were triplets. Anything or test to do to prevent multiples?
Yeah, so ultrasounds will help you. Your estrogen levels will partially help you. If you see more than 2 eggs there, don't go ahead if you're trying to avoid multiples. And even with 2 eggs, you could easily end up with triplets. I will say that we tend to use letrozole more than Clomid because the success rates are higher. And at least in our experience, the risk of multiples is much lower. And it probably is lower based on the studies as well, because typically with letrozole, you make 1 egg, and with Clomid, you'll make 2 or 3. So something to think about.
We're doing frozen embryo transfers in January. I've heard you talk about NAC for endometriosis.
Yep.
Should I start now?
Yes.
I've been on 3 months Lupron and letrozole.
Yes, you should start now. NAC, inositol, NAC, coenzyme Q10, and curcumin. Or we use a product called Theracumin, but it's the same thing. So go ahead and start all 3 of those as soon as possible. They will be helpful.
What supplements do you suggest taking while waiting for an FET?
Well, it depends on what's wrong. If you don't have anything wrong, your vitamins, vitamin B12, iron, vitamin D, your omega-3 fish oils. There's no harm in taking things like coenzyme Q10, turmeric, stuff like that will all help. But those are the ones that are kind of the basics. If there's something wrong, then you've got to tailor it to whatever is wrong. So if you have, for example, PCOS, you want to be on inositol, NAC, coenzyme Q10. If you've got endo, you want to be NAC, coenzyme Q10, and curcumin. So it all depends on what the diagnosis is.
My RE said he'll be taking me off progesterone injections and suppositories after 10 to 12 weeks.
Yep.
I'm worried about the pregnancy without the supplemental progesterone.
Okay, so there is no evidence whatsoever that progesterone beyond the 10 to 12 weeks is useful in terms of reducing miscarriage risks. However, progesterone does reduce the rates of preterm labor. And so we actually keep our patients on vaginal progesterone, not the oil shots, because that's painful for the whole pregnancy, but we keep our patients on vaginal progesterone up until 36 weeks. And I do firmly believe we have a much lower rate of preterm labor than normal. So normal is about 10 to 15%, and we're not even close to that. So I do believe that it works and that it reduces the preterm labor rate, but it will not make a difference for your miscarriage.
Hey, Dr. V. and Tarek.
And Tarek, You're in there, man.
Is there anything you can do to get rid of lumps caused by PIO injections?
So a lot of times if you're getting lumps, we actually tell you to stop because those are those big pink or red welts that you get, and it's like an immune reaction to the PIO. If you're getting those, we want to stop it. So if you're our patient, and I don't know who you are because Tarek's reading the questions, then call us and stop the PIO injections for sure. Otherwise, no, there actually isn't a way. You can change formulations. Remember that progesterone always comes in some kind of oil. So there's like peanut oil, sesame oil. So if you're, reacting to one, you may not react to the other. It's not the progesterone you're reacting to. It's actually the oil base that you're reacting to.
Exercise in early pregnancy. BC skate skier here. Oh, BC skate skier here. Or weightlifting.
I'm totally jealous. Skiing, yes, Tark and I are totally jealous. I definitely would not advocate for skiing while you're pregnant. Even if you're an amazing skier, one bad fall and you're probably risking stuff. So if you were doing cross country and it was low impact, that's fine. If you're going downhill, I certainly would not advocate for downhill boarding, snowboarding, or skiing if you're pregnant. Yeah, that's probably not a great idea. Yeah. Tarek and I, however, will happily take any spots you have skiing out west and go in your place and definitely tell you how wonderful it was. Yes.
We had our first IUI today.
Oh, fantastic.
My husband's sperm count was 6 million post-wash.
Okay.
Is this okay? Also, his last analysis wasn't great about 3 months ago, and we've been taking supplements. Are we able to do an updated sperm analysis?
You can certainly do an updated sperm analysis. It's free. It's easy. We're happy to do that. 6 million is a little bit on the low side. You want a minimum of 9, but it's pretty close. So hopefully that's still okay. But somewhere between 9 and 14 are the optimal numbers. We actually have 2 videos on that exact topic. Just like I think they were around a year apart. One showed that 9 million was the minimum, and the other one showed that 14 million was the minimum. So below those thresholds, it did show a decrease in success. So we may see a decrease, but it doesn't go down to 0. It just goes down to being less than what you ideally want it to be.
What's the cost difference to ICI versus traditional IVF?
Well, we don't do ICI because that's called intercourse. ICI is depositing the sperm at the cervix or in the cervix, which is useless. Like there's absolutely no value to do that. So if you're talking about doing IUI, where we inject it into the uterus versus IVF, it's a minimum of a 20-fold increase. So an IUI with us is $350 for the basic version, and the cheapest IVF package we have is about $62.50, and that's for just one egg. So you're looking at roughly what would that work out to? About 17-fold, yeah, 17-fold or 16-fold difference. By the time you get up to our normal standard IVF package, which is $10,745, you're looking at over a 20-fold difference in cost. But with IUI, you're getting a 10 to 15% chance with pills, maybe a 20% chance with shots. With IVF, depending on your age, you're looking at anywhere from, a guarantee with us down to, low chances if you're 44 or 45. But still, nevertheless, always going to be much, much, much higher than IUI.
Can you briefly discuss a DE cycle in a premenopausal woman? Are hormones and treatment any different than a traditional IVF cycle?
So DE stands for donor egg. DE cycle, we just put you and the donor on birth control pill to line up your periods. We don't always do that, but we often do. And then we can set it up so that you'll be ready when she's making the embryos for us. So basically we do her egg harvest, we make her embryos, and while we're getting that part done, we're getting your uterus ready with our hormone protocol or treatment protocol. It's really an anti-hormone protocol to get your lining ready for the implantation of the embryo. Once you've retrieved our eggs and started the embryos, at that same time, we want to start your progesterone to increase the chances that we are going to be successful with the implantation of the embryo. And then you should be able to do a fresh transfer, assuming that you have a wonderful set of blastocysts, or at least one blastocyst. The only issues are if you are choosing to do, for any reason, pre-implantation genetic testing, then there needs to be a gap of time, so you don't really need the birth control pill. That may alter things, or if there's something unique about you like endometriosis and whatnot. As far as hormones are concerned, we really have a fairly low hormone approach to doing our embryo transfers. So we use letrozole instead of estrogen. We only use estrogen when we need to. A lot of supplements, vitamins, healthy diet, natural approaches. And then on top of that, we also add in using other products that will facilitate things like vitamin D, the omega-3 fatty acids, and so on. We use probiotics, we use antibiotics, like there's a whole protocol for us. Progesterone is a critical element, and we do monitor it very, very carefully.
Dr. Victory, what we can do for abnormal shape of uterus after fibroids removal to conceive? Thank you.
Oh, well, if they damage the inside of your uterus at the time of the fibroid removal, you can try to have it recreated. So we can go in with the camera and cut the scarring to bring it back to a more normal shape. Doesn't always stay fixed, but it's worth a shot. So that's an option.
Dr. Victory, is it possible to complete an IVF cycle without using Lupron? Thank you.
Not everybody needs Lupron. However, it depends on what part of your cycle you're talking about using Lupron for. So in years gone by, we used to use Lupron to prevent women from releasing their eggs. But if you're using Lupron down regulation as opposed to the microdose flare, you have to use an HCG trigger, or else you're not going to get enough of an LH type surge to release the eggs. So high levels of HCG are then a risk factor for ovarian hyperstimulation syndrome. That's the first part of it. If you're using the Lupron in a microdose flare, or you're using it as a trigger shot, which we often do, then you should be using Lupron for microdose flare because it works well. And you should be using Lupron as a trigger shot in cycles where you're on an antagonist, because it has been proven that the Lupron trigger with a small amount of HCG reduces your chances of ovarian hyperstimulation syndrome, but also still gives you very, very high quality embryos with very high quality success rates, not high quality, very high success rates at embryo transfer. So that's something we would definitely advocate for. So if you're using it for down regulation, it's a little bit of an older approach to things. There's nothing wrong with it, but it is an older approach and limits what you can do for trigger. If you are using it for trigger or for microdose flare approach to things, well then yes, you should be using it. So you don't have to, but you should, because it actually improves your chances.
We're doing a frozen embryo transfer in January.
Okay.
I've heard you talk about NAC for endometriosis. Should I start it now? I've been on 3 months of Lupron and letrozole.
That was the same question.
Okay.
Yeah. Yes. Again.
What supplements do you suggest taking while waiting for an FET?
I think we had that one too. Did we go back somehow? Yeah, we've been through the supplements. And
40-year-olds pro 18 eggs, 40-year-old PRO 18 eggs,
okay.
15 fertilized, 6 blasts, waiting for PGTA results.
Okay.
More oops. More is coming. And then, oops.
Yeah.
40-year-old, 18 eggs, 15 fertilized, 6 blasts,
Okay.
waiting on PGTA results.
Okay.
Higher number of blasts in a 40-year-old group mean poorer quality?
No, absolutely not. Your blasts are your blasts. And if you have lots of eggs, your 18 eggs at 40, you probably actually have better quality most of the time. So, you're still going to face the standard statistics as far as the rate of aneuploidy, meaning embryos that are not genetically normal, but there's no reason why the quality of your embryos would be compromised because you made more. If anything, arguably, it should be better.
Did Lupron people for January FET prep had a period 2 weeks later, but continue spotting since? Is this normal?
No, It depends. I mean, if it was 2 weeks ago and you are, well, it depends on when your period was, but if it's been more than like 7, 8 days, you're still spotting that cycle, there's got to be something wrong. So you need evaluation.
Would you take anything other than a prenatal and vitamin D in a 2-week wait?
Yeah, again, it depends on your diagnosis. The omega-3 fatty acids, vitamin E, vitamin D, vitamin C. And make sure you're taking iron, B12, acupuncture, meditation, prayer, anything that will calm you is really good. No smoking, no drinking, no drug use. Those are really helpful. All of those sorts of things. Mediterranean diet can be useful. And then if you have PCOS, inositol, NAC, coenzyme Q10. If you have endo, it's NAC, coenzyme Q10, and curcumin. So those are the supplements for your FET.
Hey, Dr. V.
Hey, Dr. V.
That's it. That's what you know. Not sure if any of this has been asked, but 1, do you suggest doing acupuncture before a transfer? If so, any recommendations of who to see? 2, how long after doing a booster is it safe to do a transfer?
You should wait at least a month after your booster to do a transfer. So I'll answer the second part first. And then as far as who to recommend, we obviously use Jen Strong because she's part of our clinic. So I love Dr. Strong. She's amazing. And she's a wonderful person, great at acupuncture. Do we recommend it? There are multiple studies which have shown a benefit to acupuncture and multiple studies that have not shown a benefit to acupuncture. The overall gist and the kind of philosophy behind this is that if when you do acupuncture you feel more relaxed, then it will likely be beneficial. And if when you do acupuncture you're cringing or you just don't believe in it or you don't think it's doing anything for you, it's not likely going to have an effect. So it probably has more to do with how you feel about it and your physiological response to it, like in terms of it relaxes you, it calms you, than it does to any blood flow direction to your uterus or your ovaries or anything like that.
I have a bilateral
Hydrosalpinx. Yeah.
Salpinx.
Yeah.
And my doctor performed a tubal ligation to prep me for IVF. I had a failed FET with a normal embryo. Do you recommend I ask my doctor to remove the tubes completely?
Yeah. Absolutely.
Remove the tubes to improve implantation?
So clipping your tubes for hydrosalpinx actually is quite risky because now you've trapped fluid between whatever closed end there is. And you want me to draw it?
Do you?
Oh, yeah, sure. All right, let's do that. I'll have to pick up a fallopian tube picture. All right, we're going to use the iPad. Hang on a second. And I don't know if we ever got a draw app on this thing, did we?
Yeah, the pencil one.
Which pencil one? I don't think I have a draw app on this thing, do we? All right, but that's okay. You know what? I can do it in a picture, so hang on. We will do this. I will in 1 second. I know the audience is getting excited. Thumbs up for this. Okay, let's find a picture. God, I hope this doesn't pull up something pornographic. Okay, so let's get a nice big picture of fallopian tubes. We'll blow this one up for you guys. The anatomy of the fallopian tubes. Okay, so that's your picture there. I'm just going to move it to one side so you guys can see. So, right, let's do this. Oh, I can't, I need to do it as a picture. I forgot about that. Does this do? No, I need to figure out how to do a screenshot. Okay, so you guys can all see the fallopian tube there. And so if you're seeing the fallopian tube, Tara, can you use your pointer? Will it show up for them?
No, I can't. That's your screen.
I can't, and I can't draw on the internet.
It's like home and volume button, I think.
I tried that. It didn't work.
Oh.
Let me see if I do it again. No, unless it's this. Nope.
No.
Okay. So in the uterus, in the fallopian tube there, if you have swelling in the tube, and you clip one end of it, the side, let's say close to the uterus, which is where they're going to clip it, You now have a closed tube on one side and you've got a closed tube on the other side, and you just created an abscess, because if there's any bacteria in there, it's going to accumulate and get infected. Worse, if there's fluid in there, the fluid tends to continue to build, in which case you're going to get horrible pain as your tube gets more and more and more stretched. So I never clip tubes. If you're going into deal with a hydrosalpinx, you remove the tube. I'm sure I could probably find pictures of hydrosalpinx, and trust me, they're not necessarily pretty. And when you see those pictures, it's a problem, because what we run into is, here's a cartoon picture so we don't get in trouble with any of our social media friends. So when you see these hydrosalpinges, you'll very quickly understand. See how swollen that tube is there? If I block it off close to the uterus, I just created this huge swollen mass, and it's very high risk of further swelling, very high risk of infection. Always get them removed. A clip is not enough to block the fluid anyways. We have people that get pregnant after they have clips because the dye will get through. So the fluid will leak through. This fluid is chock full of inflammatory mediators, and that's what's preventing implantation from occurring. We got to figure that out.
We're almost there.
We need to draw it up. Go.
I've been in an immune protocol, including IVIG, and have made it to 18 weeks.
Okay.
Eager for the booster, but also nervous given prior loss potentially due to immune issues and inflammation.
At 18 weeks, your risk of loss would be considered negligible. I'm not going to take responsibility for whatever happens here, because I'm just the guy answering questions, but I would not tell any of my patients to not take the booster that far into a pregnancy because of an immune issue or being on an immune protocol. Having said that, being on IVIG may very severely restrict the function of the vaccine in general in you, and therefore it is questionable as to whether or not it's even valuable, because I have no idea what your immune response will be like. I did look up immune response in people with lupus who were on various immune protocols, and they still recommended that that they be vaccinated, and that there are benefits in groups where they are immunosuppressed. So it is still recommended, but specifically patients on IVIG, I don't know about that data, and that's something we'd have to look up. Very, very few people are on IVIG because it is so darn expensive. So you're a very special group of people. I'd have to look up what the outcomes are of people on IVIG who have received the vaccine. I'm sure it's available somewhere. Someone must have studied it. I just don't know what those results are. I would imagine that you're going to have a lower response rate.
How can I get rid of fibroids without surgery? Is it okay to take inositol and metformin?
There is no way to get rid of fibroids without surgery. You can shrink them. You can reduce their impact. You can even kind of kill them with certain things, but you cannot get rid of them unless you do surgery. I have had people try and tell me that they would try everything from high-dose vitamin C to praying to the Lord. Unfortunately, the Lord put him there, and he's not going to take him away with prayer. So you cannot get rid of fibroids just with conventional techniques. There is no medication that will eliminate fibroids. The best of what we had was Fibristol, which unfortunately started damaging women's livers, and so they pulled it from the market. But Fibristol shrank them at the most by 75% of their volume, which still meant that a 5 centimeter fibroid ended up being like a 2.5 centimeter fibroid. You can't get rid of them. You can only reduce them in size. Surgery is the only way to get rid of them.
Correction in spelling for the ICI, it seems to be ICSI.
Oh, what's the difference in cost between ICSI and conventional IVF? So I have kind of a different model for IVF. We don't nickel and dime people for, hey, we're adding this and we're adding that, unless you make a ton of embryos, in which case we charge for more than a certain number of embryos, but we just bundle everything into a package. Doesn't really matter what you're getting. It's all there in the package. So here's your price. You're, paying for everything all at once. We're the Saturn dealership of, of IVF. Yeah. It's one price. Everything's included. We do ICSI for all our patients. Now, how much do most places charge for ICSI? $1,500, $1,800, $2,000. But it depends on where you're going and what you're having done.
When trying to conceive, is Zopiclone and
Zopiclone.
Zopiclone, okay, is
it's not ideal.
Clonazepam.
No,
0.5 milligrams, okay.
I gotta send Tarek to pharmacy school.
Omnicron popped in my mind.
Zopiclone you should avoid. It helps you sleep, and clonazepam is addictive, so you should not be on it. A big one.
Oh yeah.
Okay.
This one I can't even. This is huge.
Do you want me to read it?
No.
Oh, okay.
So far it's okay.
Okay.
We'll see. Dr. V, good evening.
Good evening.
And also the team at Background.
Hey, that's you. Tarek correctly identified that was him.
I would like to know what causes period C's since my last period in October. And I've gone to see the doctor and I was told to do blood work and the results just says my iron level is low. Microcystic anemia, considered iron deficiency, or
thalassemia,
hemoglobinopathy. Recommend serum ferritin and hemoglobin fractionation if status unknown, and should boost it up. And no premenopausal scene or fibroid in the blood test. Also says I'm not pregnant, but I'm so feeling sick and tired easily. Plus, I want to have a baby in the plan for the year ahead.
So just going back to the beginning, her menses ceased. Is that what she said?
Yeah, my period ceased in October. Yeah.
Like CEASCE.
No, CEIZE. Cease. What causes a period to cease?
Well, that's not the way you spell C's.
I'm just reading.
Okay, I'm not sure I understand. If your period stopped, it has nothing to do with your iron levels. It would be more hormonal. So it has to be hormonal or blockage, physical obstruction. But if your iron level is low, you need all those tests that they mentioned. I support the tests you have. But if your period stopped, it's going to be a hormonal problem. So it doesn't necessarily mean menopause. It could be PCOS. It could be changes in your weight gain. It could be the vaccine, which has had alterations in people's periods. They're all short-lived. It comes right back to normal. Don't worry. It could be problems with elevations in things like prolactin or cortisol. There's more.
Mentions that she's 45 years, beautifully young and ready.
Well, at 45, it's certainly very possible that you are actually going into menopause. So that's something where you would need to look at your hormones. And at 45, it is very difficult to get pregnant, no matter how beautiful, young, and ready you are.
Please discuss a cycle for a post-menopausal woman undergoing an FET with donor eggs. I'm 48 years old. Yeah. What are the hormonal issues, if any, with a woman such as myself?
We would still give letrozole a shot with you, but you may need estrogen. That's the main difference. Everything else is the same. Antibiotics, probiotics, vitamins, supplements, healthy diet, a little bit of exercise, acupuncture if you think it'll be beneficial for you. Make sure you're taking frequent ultrasounds. When your lining gets to 8 or 9 millimeters triple layer, we start the 2 types of progesterone, oil and vaginal. Get your levels checked, make sure your lining's getting small enough, adjust estrogen and progesterone as needed, show up for your embryo transfer.
If you only have 1 tube left and it's blocked, would you recommend jumping to IVF, or would you try to unblock the tube to try IUI?
I pride myself on being a pretty good surgeon. Unblocking tubes is extraordinarily difficult. And the studies show that even after they've been unblocked, the pregnancy rates are relatively modest and not particularly, mind-blowingly good. So I would strongly advocate for you to go directly to IVF. I do not recommend to patients who only have one tube and find out that one's blocked that they go for surgery. And this is coming from a guy that totally advocates for surgery when it's appropriate, but I don't think it works that well in that circumstance.
Hey, Dr. Vic.
Dr. Vic.
Dr. Vic.
Hey.
Yeah. New name.
New name.
I'm in BC. We're thinking about doing gestational surrogacy with you.
Awesome.
By April next year.
Okay.
Please.
Please.
How long is the waiting period to get a surrogate? And what is the cost for a large family? Thank you.
So it depends on whether or not you want to do it as a guarantee or as a single cycle. So cost can be anywhere from very reasonable all the way out to expensive if you want like a double baby guarantee. As far as the wait time, you're local because you're Canadian. Typically, it really doesn't take that long to find you someone local. And there are some new agencies out there, so I don't think it would be particularly long for you to succeed. Usually 4 to 6 months, and we can find you someone. You need embryos first, though.
901.
Yeah, it is. A couple more questions, or is there a ton of questions tonight?
No, you're almost done.
Okay.
The second part of my question was not answered. Can I take inositol and metformin?
Yes, you can take inositol and metformin.
Okay. It's better than the clip. We did the clip question, yes?
Yeah.
This is what I did. Okay. I now have five fibroids. How long should I wait after birth to have them removed?
Well, you don't need your fibroids removed unless they're causing you a problem. So if your fibroids are causing you a fertility problem, a pain problem, a sexual problem, a bleeding problem, there's lots of options, medical and surgical, and you need to explore those options. But they should only be removed if they're somehow causing a problem that needs them to be removed, infertility or heavy bleeding or whatever the case is. But you should talk to your gynecologist or your RE to see what they want to do with you in treatment.
Thoughts on immune testing and low decidulization score?
We do immune testing. I don't do a low decidulization score, but we do immune testing for patients where I believe it's going to be beneficial for them.
What is the difference of doing a natural cycle transfer versus taking Lupron prior to transfer?
A natural cycle comes in several different flavors. There's true natural, where you take nothing and you monitor the LH spike and then you start progesterone or even don't start progesterone. And then there's modified natural, where we trigger the release of your egg when it's getting to a certain size. And then there's what I call modified natural, which is we actually use letrozole. So Lupron allows you to downregulate everything ahead of time and then start whatever medication you're going to use, whether it's letrozole or estrogen, to thicken the lining. So it's not natural, it's a hormone replacement. You can look at all of these different studies on natural versus stimulated or hormone replacement cycles. There's no difference. Literally all the time, one study says one thing, the next study says the other, and then one study says one thing, and then the next study says the other.
Lupus and rheumatoid arthritis, autoimmune disease, does it impact pregnancy? Is there anything you can do to prevent miscarriages that may be caused by autoimmune disease?
Yeah, so both of those are known to cause an increased risk of miscarriage. If you have lupus, you need aspirin and heparin in particular, because you're very high risk for miscarriage, complications of thrombosis, complications with your fetus, even especially if you have lupus antibodies. There's problems with development of the fetal heart. So make sure you're on aspirin and heparin to reduce those chances. One more.
Okay.
Tarek's terminal question. Pick a good one.
Oh.
Tarek's expressions tonight have been priceless. You guys have been stumping him left, right, and center.
That's a very random comment.
Okay.
It's about the drive. It's about power. Come on, guys.
It's about the drive. It's about power.
Yeah. Some guys, I think, spam it, but I can't tell for sure.
Okay.
40% abnormal physiology of sperm is worse. What's the perception? What's the prescription?
40% what?
Abnormal physiology of sperm.
I think you mean morphology. So 40% of your sperm are abnormal, no smoking, no drinking, no drug use, weight loss, diet, exercise, take lots of fertility vitamins for men, avoid heat, avoid electromagnetic radiation, which we are putting a video out on shortly. And yeah, that's pretty much it. Sit on something cold 20 minutes a day. Stay away from hot tubs, saunas, jacuzzis. Done. Thank you very much for joining us for Fertility Fact or Fiction. We will not be back next week because it will be a holiday. So I hope you guys have a wonderful, wonderful holiday season. My love to all of you and your families, and I hope that you have a very blessed new year as well. We will be back in January, I think on the 3rd, but we will confirm for you with a whole new year of shows. And hopefully we'll have some cool new stuff to show you then too. Have a wonderful holiday, guys. Good night, and thank you for joining us on Fertility Fact or Fiction.